According to the World Health Organization, dengue has now been the fastest spreading tropical disease in the world. Over 25 billion people in 125 countries are at risk for dengue infection. 50 to 100 million infections, majority in children, occur annually. In the Western Pacific region, the Philippines has the highest incidence of dengue infection. Over the past years, dengue has recorded new geographic extensions, explosive outbreaks, and more severe cases.
The culprit? Dengue virus. Dengue virus is a spherical envelope flavivirus whose genome is a single positive sense single-stranded RNA. It has 4 serotypes dengue 1 to 4. Dengue virus is transmitted through a vector, which is an Aedes mosquito, mainly Aedes aegypti.
Clinically, dengue infection presents with fever, headache, rash, eye pain, back pain, muscle aches, and joint pain. Severe plasma leakage, hemorrhage, and organ impairment are signs of severe dengue infection. Infection starts with the entry of the virus into the human skin through infected mosquito bite. Upon entry, it undergoes a 4 to 10 day incubation period, which is the time for the virus to replicate and infect other cells.
Dengue infection has 3 phases. The febrile phase, characterized by the onset of fever and other symptoms and viremia. The critical phase, characterized by the significant decrease in platelet and hemorrhage or organ impairment. And recovery phase, characterized by the return of hematocrit and platelet levels to normal and production of antibodies. The antibody-dependent enhancement mechanism can explain severe dengue infection. The cross-reactive antibodies from previous infection facilitate infection of more cells, producing the severe manifestation of the disease.
The diagnosis of dengue infection is mainly clinical, confirmed by laboratory findings such as complete blood count and detection of antibodies or viral antigens, virus isolation, PCR, etc. Patients are managed symptomatically by hydration and antipyretic drugs, and intravenous fluid resuscitation and plasma replacement for severe cases.
Recently, there has been development in the search for novel drugs for dengue, like bioflavonoid 6-methylmercaptopurine riboside, a glycan analog of teicoplanin, siRNA, lovastatin, and Draco. The bioflavonoid quercetin exhibits antiviral activity by inhibiting RNA polymerases needed for the replication of the virus inside the host cell. Bicalane has direct virucidal activity targeting adsorption and replication of the virus.
6-methylmercaptopurine riboside, which is a thiopurine drug, inhibits production of flaviviruses such as dengue virus, yellow fever virus, and West Nile virus. A glycan analog of teicoplanin inhibits viral entry into host cells by targeting one of the structural proteins. Synthetic small interfering RNA targets the highly conserved 5' cyclization sequence region of the dengue virus genome. Lovastatin, which is a lipid-lowering drug, is being studied for symptomatic treatment of dengue due to its ability to restore and improve endothelial cell function. Double-stranded RNA-activated caspase oligomerizer, or Draco, is a broad-spectrum antiviral agent that selectively induces apoptosis of virus-infected cells while not harming the unaffected cells.
The quest for drugs against dengue continues. With the advancing technology, many studies on diagnosis and treatment of dengue are being conducted. Like in other diseases, early diagnosis is critical for proper treatment of the disease.
Created using Powtoon.